All right, let's just dive right into this explainer and completely dismantle the rigid, traditional way we've all been taught to do neurological exams. I mean, if you've ever tried to march straight through cranial nerves 1 to 12 on a squirming toddler, you know exactly how fast that goes entirely off the rails. It's a nightmare, right? So today, we're focusing strictly on pediatric patients. We are talking about kids here, not adults. We're going to look at a fundamentally better, far more practical way to assess these little ones without losing their cooperation 5 seconds into the visit. To do that, we're going to break things down into 6 quick parts: rethinking the neurological exam, vision covering acuity and fields, the oculomotor dashboard, the squint matrix and eye movements, assessing the face, hearing, and neck, and finally, how this all fits into the complete clinical flow. So part 1, rethinking the exam and exactly why testing 1 through 12 fails miserably with kids. Look, the clinical reality is that jumping around a child's body, checking their eyes, then their shoulders, then their jaw, just to satisfy some numerical list, it creates anxiety. It's too much chaotic movement. The fix? We group the exam into 3 physical zones. Zone 1 is the visual system, Zone 2 is the face and jaw, and Zone 3 is the lower system. By doing this, we minimize patient repositioning. You just stay in one physical area, kind of make a fun game out of it, and maximize their cooperation. Moving on to part 2, let's look at the first zone, vision, specifically acuity and fields, and what we call the visual cascade. When we check visual acuity, we're definitely not just guessing. We follow a super logical step-down process, the visual cascade. You always start with a Rosenbaum pocket card for close acuity. Hold it roughly 14 inches away, test one eye at a time, and have the child identify shapes or letters. Now here's the kicker. You only move to the next step if the patient actually fails the current one. So if they can't read the Rosenbaum card, you step back to 5 feet and ask them to count your fingers. If they fail that, you step into 2 feet and check for hand motion. If they still can't track that, you test light projection, seeing if they can tell which corner a light is coming from. And finally, basic light perception, which is just seeing if they blink to a bright flash. It's a very precise, structured cascade. Once you've checked acuity, you seamlessly transition into visual fields. Sit exactly 50 centimeters away from the child. Have them look right at your nose. Then, take a brightly colored toy and wiggle it across the 4 diagonal quadrants. And guys, here is a massive clinical pearl for pediatrics. Do not expect verbal cues. Don't sit there waiting for a 3-year-old to say, "Ah, yes, doctor, I see the toy in my peripheral vision." It's just not going to happen. Instead, watch their eyes. They will reflexively break their gaze and dart their eyes toward that wiggling object the second it enters their visual field. That simple ocular reflex, that is your confirmation. Which brings us to part 3, the oculomotor dashboard, covering cranial nerves 3, 4, and 6. Now, before we ever ask a child to actually follow a toy, we have to just sit back and observe their eye alignment at rest. This is absolutely vital. We are looking for anaphoria, which is a latent drift that only really happens when their visual fusion is broken, or atropia, which is a constant obvious visual misalignment. Specifically, pay attention to the position of the eye. Esotropia means the eye is resting in a medial or inward position. Exotropia means the eye is drifting lateral or outward. Catching this resting state right off the bat dictates the entire rest of your motor exam. The big idea here is treating nerves 3, 4, and 6 as one cohesive oculomotor dashboard. Instead of trying to somehow isolate cranial nerve 4 from nerve 6 in a squirming toddler, which is near impossible, you evaluate the whole dashboard at once. You check alignment, look for any nystagmus, check for ptosis or a drooping eyelid, watch their conjugate eye movements, and test pupillary responses. It's a one-stop, all-in-one visual inspection. And when we're testing those pupillary reflexes on our dashboard, we have to be methodical. First, just assess the resting size of the pupils. Simple enough. Then, test the direct reflex. Shine your pen light into the right eye and watch that right pupil constrict. Next is the indirect or consensual reflex. For this, you shine the light into the right eye again, but this time you're staring at the left pupil. It should also constrict because that neural pathway crosses over in the brainstem. Finally, test the accommodation reflex. Bring a fun little toy right up to their nose. You should see both of their eyes converge inward and their pupils constrict as they try to focus on that mere object. All right, part 4, the squint matrix and eye movements. Let's talk paralytic versus concomitant. We really need to distinguish between a paralytic and a concomitant squint. If an extraocular muscle is actually paralyzed, let's say a 6th nerve palsy with a lateral rectus just fails completely, that squint is paralytic. The eye is going to rest inward in an esotropia because the medial pull is totally unopposed. On the flip side, if it's a third nerve palsy, the eye rests down and out. In these paralytic cases, extraocular movement is restricted, and the child gets maximum double vision, or diplopia, when they try to look in the direction of that paralyzed muscle. We diagnose this using the cover-on-cover test. You cover the healthy eye, which removes its ability to fixate, and carefully watch that misaligned eye. It'll quickly jump to take up fixation. Now, contrast all of that with a concomitant squint. This is often due to central coordination issues, like in cerebral palsy, where the amount of misalignment is exactly the same in all directions of gaze, and the actual eye movements remain fully intact. So how do we systematically check those conjugate eye movements? Well, we're looking for two specific things. First, saccades. Hold up a red toy in one hand and a blue toy in the other. Ask the child to look at red, then blue, then back to red. You're watching for rapid, precise, crisp jumps of the eyes. Second, we test pursuits. This is your smooth, continuous tracking. Take one toy and slowly move it in a wide H pattern. Make sure you test those extreme ranges of gaze to verify that all the extraocular muscles are working together nicely. Moving right along to part 5, the face, hearing, and neck. This covers anatomical groups 2 and 3. For any undergraduate students tuning in and trying to memorize this, the absolute easiest way to master the trigeminal nerve, cranial nerve V, is the rule of 3. Just think of it as 3 distinct jobs. One motor job, testing the muscles of mastication by feeling them clench their jaw. One sensory job, checking light touch across the ophthalmic, maxillary, and mandibular branches. And one reflex, the corneal reflex. If you just lock in the rule of 3, you will literally never miss a step on cranial nerve 5. When it comes to cranial nerve 7, the facial nerve, you've got to remember the classic tale of two palsies. It is absolutely critical to differentiate your facial nerve lesions. An upper motor neuron lesion, like what you'd see from a stroke, actually spares the upper face. The child can still wrinkle their forehead because that specific area receives bilateral cortical innervation. But a lower motor neuron lesion, like Bell's palsy, knocks out the nerve after it has already exited the brainstem, causing severe, obvious weakness across the entire half of the face, from top to bottom. Let's slide down to cranial nerve 8, the vestibulocochlear nerve. Obviously, you can't ask a tiny baby if they hear a tuning fork, right? So for infants, we use the habituation test. While they're feeding, you just ring a small bell out of their sight and watch for a sudden pause in their suckling. That little hesitation, that pause, that is your proof of hearing. Once they're older children, you can level up to whispered sounds at 15 centimeters, finger rubbing, and your classic Weber and Rene tests with a 512 Hz tuning fork. Now, when we get to assessing the lower nerves, specifically cranial nerves 9 and 10, please remember this golden rule in pediatrics. Defer the gag reflex. Seriously, do not stick a tongue depressor down a toddler's throat unless it is absolutely, strictly medically necessary. If the child is feeding well, swallowing their saliva normally, and speaking without a nasal twang or having nasal regurgitation, you can safely assume nerves 9 and 10 are intact. Testing the gag reflex unnecessarily is literally the fastest way to make a child instantly and permanently uncooperative for the rest of your exam. Just don't do it. Finally, we wrap up Zone 3 by checking the spinal accessory nerve, cranial nerve 11. Keep it fun, make it a game. Have the child shrug their little shoulders up against your hands and have them push their cheek into your hand to test that sternocleidomastoid muscle. Then, observe the hypoglossal nerve, cranial nerve 12. Have them stick their tongues straight out. If there's a lower motor neuron lesion, the tongue will reliably deviate toward the weak, paralyzed side. Why? Because the healthy muscle on the opposite side is pushing it over all by itself, completely unopposed. And finally, part 6, the complete clinical flow. Let's look at the whole logical blueprint. All these grouped cranial nerves we just walked through, they are actually step 5 in the complete clinical flow. You don't just walk in and start testing cranial nerves. You start with observation from the doorway, then you select your coma or awareness scale. Next, you test their attention span using digit recall, evaluate their higher cognitive functions, and only then do you move into these anatomically grouped cranial nerves. It's designed to be a deliberate, completely frictionless sequence. So what's the big takeaway from this whole explainer? It's that the neurological exam isn't just some random assortment of textbook tests. It is a logically sequenced blueprint built around actual human anatomy and realistic pediatric behavior. By grouping the visual system, the face, and the lower nerves, you make the exam fast, efficient, and pretty painless. Which really leaves us to ask, the next time you walk into a clinic room with a nervous 3-year-old, are you going to adapt your exam to the patient right in front of you? Or are you going to try to force that patient to adapt to your rigid checklist? Something to think about? Thanks for learning with us today, and we'll see you in the next explainer.